We are back with the COVID Sense series. The goal of this series is to help you understand the evidence so you can make informed decisions regarding COVID. This is the first segment in our series on informed choice. Today, we'll be looking at COVID and pregnancy. We have Deanna McLeod, principal at Kaleidoscope Strategic, here to walk us through some more of the data.
There's been a lot in the headlines recently in Toronto about the risk of pregnancy and COVID. This particular headline was announcing that 30% of the people in Mount Sinai ICU were pregnant or postpartum. There was some concern that a lot of this was with respect to the third wave in the effective variants. And there was a little tweet from the Ontario Society of OB-GYNs saying that the Ontario ICUs and delivery rooms are overwhelmed with pregnant women with severe COVID-19. And that they need to have a prioritization in terms of vaccination. A friend of mine was called, she's 6 months pregnant, and she was told to make an appointment to get the vaccine right away. So what are we to do in this particular situation? What is the evidence? What are the risks and benefits of vaccination in this particular context? So one of the things that we're going to touch on right away is this concept of informed consent. So informed consent is where you're given the time and access to a qualified health professional to walk through the risks and benefits of treatment and to really carefully weigh those so that you can make a good choice both for yourself and your baby. So ideally, this healthcare professional will know the data. They'll be familiar with your treatment and health history. You'll be familiar with your risks and also your personal preferences. So if you haven't yet had a chance to talk to a healthcare professional, make sure to do that. This decision should not be based on fear. We always tend to make bad decisions when we're fueled by fear. And the other thing too is when you're talking to your healthcare professional, make sure that they've actually looked and reviewed the published data themselves and are not referring or relying on recommendations from anybody. We want somebody who's going to be able to walk us through the evidence. And if you haven't had a chance to walk through the evidence, we have series on both the safety and the efficacy of vaccines for the population in general on our channel. So let's take a look at where a lot of this concern is coming from. So this is basically a report in the Morbidity and Mortality Weekly. Basically, it's a publication from the CDC, and it's a report on an analysis of their COVID database from January 22nd to October 3rd, 2020. In this particular analysis, they were looking at outcomes for symptomatic women for which they had pregnancy data specifically. Now, one thing that before we get into discussing this particular analysis, what we want to do is remember that the US COVID database is a passive surveillance system, meaning that people, they might not have all the recorded cases of confirmed COVID. They basically are capturing reports of more severe disease or those who've actually had confirmed PCR tests, and it underreports cases overall because many people with mild to moderate COVID would probably have sheltered at home, especially in the first part of this particular pandemic. So one of the things that we need to look at here is that this was looking at, so we've got all cases of COVID, those that were confirmed by PCR reported in this particular database. And this database captures all confirmed cases. So there were 5 million of them. Of these, basically, about 1.3 million were aged between 15 and 44, which are childbearing years, of which they had pregnancy data on 461,000. And of that, 409,000 were symptomatic. And of those, 23,434 were pregnant. So what we're looking at is from the total population of women, we're looking at 1.8% of all women. So right away, what we need to think about is that this is quite a subselection of the database. It's also important to note that in this subsection here, that 11.3% of women were asymptomatic. So that would include women who were pregnant. So right out of the gate, we want to talk about the fact that there were a segment of women who were asymptomatic that were not included in this analysis. So if we're going to be generalizing these results to people in general, then we would have to include, or we have to lower the rate because it excluded women who were asymptomatic, and there were at least 10% of these, or 11,000 women per 100K. So when they looked at the analysis, they were comparing women who were symptomatic, who were pregnant, versus women in their database for which they had pregnancy data who were not symptomatic, again here. So one of the things that we want to look at is that the women included in this analysis actually were not representative of the total population of women as a whole, or all of the cases of COVID that occurred in the United States. It basically represents a subselection of women for which they had pregnancy data. So when they looked at the comparison, they saw that 1,000 women were per 100K, this is per 100K, 1,000 women per 100K were admitted into the ICU ward versus for pregnant women versus non-pregnant women for which they had pregnancy data, there were only 390. Again, when we think about ventilation, there was a higher frequency here than here. Requiring oxygen, again, increased with pregnancy, and a slight increased rate of death with pregnancy. When they looked at risk factors, they did adjust for risk factors. So they adjusted for age, diabetes, cardiovascular disease, and lung disease at database. And when they did that analysis, they continued to see that pregnancy was a lead factor for more severe COVID. They also saw that women who were aged 35 to 44 years were at an increased risk of death, along with the higher rates of death for women who were Black. The authors conclude that although the overall absolute risk of severe COVID is low, that it might be higher for pregnant women rather than non-pregnant women. So again, this particular analysis, which draws on 1.3 million cases of COVID and looks at 23,000 cases of pregnant, is the biggest, the largest analysis regarding risk of COVID, probably the most reliable. And the authors here conclude that the overall risk is low. So let's go on and take a look at some Canadian data. So here we have the Canadian COVID database. Again, it's a Canadian COVID surveillance system. So once again, it underreports the number of women with COVID because women or people who have mild to moderate disease may not, especially at the beginning of the pandemic, may not have gotten a confirmed PCR test, so they wouldn't be recorded in this particular database. This database includes about 1 million people, so 1,149K. Of those, 582 were women, and of those, 288 were of childbearing years. And when you look at outcomes for that age group, what you see is that overall, about 1,742 per 100K of women are hospitalized, even fewer, 260 go to the ICU, and 48 are deaths. So again, the numbers are probably a lot lower because this does not include most mild to moderate disease. However, I think that in Canada, that would be a reasonable baseline for women regardless of pregnancy. There is a pregnancy registry for COVID, and so it's called the COVID Preg Registry. And in this particular registry, they have 2,143 recorded cases. When they did their particular analysis, they pulled 869, which is about 41% of their thing, and they had hospital data on 353. So they did an analysis, which they called preliminary, which represents about 16% of the pregnancies that they're in their registry. What they saw was that around 11,000 women out of per 100,000 were hospitalized, and 2,400 were in the ICU. So basically, these numbers are considerably higher, but again, we're looking at very small numbers in terms of total patients. They did find that there were about 15% of preterm births. So the findings basically say that in these preliminary findings, there might be a slight increased risk of severe disease. However, that the data is still preliminary, and it really only represents BC, Alberta, and Ontario, which is about 60% of pregnancies in Canada. So of the pregnancies in Canada, there's a subset, and we're only looking at about 16%. So overall, I would say that there's probably potentially some risk increase, but it's hard to say exactly what the magnitude is. All right, so now we're going to turn our attention to outcomes, pregnancy outcomes. So we know that pregnant women might be associated with more severe disease, but how do their unborn children do? So what we're going to do right now is look at this systematic review and meta-analysis of observational studies. Basically, it was published in the CMAJ by Way and colleagues in April of this year, so it's brand new data. And one of the things that they looked at were basically observational studies. And so that means that they're looking at the disease course over time. However, because they don't really have any controls, and because there's no randomization, we're not really able to develop a causal relationship. So we can't say that something actually causes something else, but we can say that there's a strong association or a weak association between two different factors. So when they actually looked at the association between COVID-19 and adverse pregnancy outcomes, they did see an increased risk of preeclampsia, preterm birth, and stillbirth with COVID-19. And when they looked at severe disease, people who came down with severe COVID, they noticed that was an increase of preeclampsia, preterm birth, diabetes, and low weight, and that preeclampsia and preterm birth were higher. So these weren't fatal outcomes, but definitely not favorable outcomes. As they didn't have access to patient records, they weren't able to adjust for baseline factors to see if there were any other variables that might be explaining these outcomes. So at this point, what we do know is that based on available data of observational studies, that there is this association, this potential association between COVID-19 and adverse pregnancy outcomes, and that they're worse with severe disease than they are with moderate to mild disease. So let's consider our risks and benefits and what the data has told us so far around the risk of COVID-19. So what we need to think about are, in terms of risk assessment for COVID, we need to think about, are you going to be exposed to COVID at all? If you're not exposed to COVID at all, there's no risk of severe disease. So if you're able to isolate and you're able to surround yourself with people who are immune, then your risk of COVID might be quite low. And therefore you would have a zero risk. However, if you do contract COVID, of all the women who did contract COVID, 98,000 per 100K had mild to moderate disease. Those are pregnant women. And 12 of those 98K had asymptomatic disease. So basically had no symptoms whatsoever. We do know that if you do contract COVID, that basically you confer natural immunity to both yourself, which is broad and long lasting, as well as to your baby. So it is possible, however, that some women, exactly 1,000 per 100K, may be at risk of severe disease. We know that there's comorbid factors, weight, diabetes, etc., that might explain or increase your risk of severe disease. As well. And we also know that severe COVID confers negative pregnancy outcomes to your baby. So particularly an odds ratio or an increased risk of an odds ratio of 4 for preterm birth and preeclampsia. So what is potentially causing all of these adverse outcomes? Well, we know that the spike protein, which is the protein that the COVID-19 virus uses to enter the cells, is pathogenic. Pathogenic means it causes disease. We are familiar, there's two established ways in which it causes disease. One is through inflammation. It is able to turn on inflammatory pathways through the body, and that is what explains cytokine storm. We also know that it's prothrombotic, meaning that it can cause either coagulation of platelets So the ACE2 inhibitor that this spike protein binds to, there's a high expression of those on platelets, and so that can cause clotting. There's also preliminary data suggesting that it might cause an increase in bleeding as the platelets are cleared by the immune system when they're infected with COVID-19. So we do know that there's some degree of pathogenesis and that a lot of that has to do with the spike protein. So what are our options? So we've already talked about one option if you are at risk of severe disease, which is, or if you're pregnant, which is to basically social isolation, which basically means you avoid contact with the pathogen or with COVID-19. A second one could be vaccination. So what is vaccination? There's a video on vaccination where you can get more information, but basically through introduction of the mRNA, the vaccine teaches your body how to make the spike protein. So you can see here that this is a little picture of the virus, and it takes the spike protein. It basically introduces the mRNA into your cells, and here your ribosomes develop mass amounts of spike proteins, which then spill into your system, and your immune system mounts a defense or makes antibodies to those spike proteins. So there were randomized controlled trials that basically assess the benefits of the vaccine. The trials that are practice changing are phase 3 trials. And in those phase 3 trials, there were 2 that were conducted and published and available for public scrutiny of the mRNA vaccines, and that was the Moderna and the Pfizer. Basically, they did not include any pregnant women. So in terms of the safety and efficacy of the vaccine in pregnant women, there is no randomized controlled data. So we have not proven that the vaccine is safe and effective in pregnant women. However, there have been real world trials that have administered the vaccine, and we'll take a look at those. However, we don't really want to rely on real world trials or real world data because they don't do a very good job of collecting safety data, and they don't have any control. So we can't actually prove that anything happens. We can only suspect. So not something that you want to do. So a good way of thinking about this is if you're in a war zone and you've got the military and they're going through enemy territory, a randomized controlled trial is like going ahead and clearing the area and making sure that there's nothing dangerous in the area, and then allowing the civilians to come through. When you don't do a randomized controlled trial, it's basically ushering the civilians into enemy territory and saying that you don't see any sniper fire at this point, so it's probably safe. We don't really want to be in that guessing game. We want to be able to say with certainty whether something's safe or not. And at this case, we can't actually say that about the vaccine in pregnant women. So if we do look at the vaccine in healthy adults that were not pregnant, one of the things that we can say based on the published data, which is the 4-month data, is that in 1%, there was a net reduction in the number of cases of COVID with the vaccine. So for both the biotech Pfizer one and the Moderna one, and that there was a net increase of about 15% with COVID-like symptoms for the first dose, all the way up to 50% for the second dose. So one of the things that we do know with the vaccines is that they can reduce the number of cases in a small subgroup of people, but in most of the people that are exposed to the vaccine, they will cause adverse events, COVID-like symptoms. And the reason for that is that they're introducing the spike protein, which is the pathogenic protein, into your body when you're giving you the vaccine. So let's go on to the real world data that we have. So again, this is not a randomized controlled trial. This is where they gave pregnant women a vaccine and basically looked at outcomes. So there's what they call a Safe Registry. It's where they do active surveillance. They actively monitor women who've been given the vaccine, looking for side effects and considering safety. Again, because it's not a randomized controlled trial, we can't make any conclusive findings about this regarding either efficacy or safety. So they did record from the women between December 14th and February 28th that women who got the vaccine, we're looking at severe side effects here. Basically, 12.6% of women, pregnant women who got the vaccine had severe adverse effects. That they were mostly muscle aches, fatigue, muscle aches, injection site pain, headache, and chills. So we do know that the vaccine does cause severe outcomes or severe side effects. And that would basically mean that they're so bad that you can't carry on your day. So the side effects, the severe side effects, were similar between pregnant and non-pregnant women. And again, because the data is short-lived in the sense that it was only from December to February, which is 3 months, we have no understanding of what the long-term data is. So what do we see in terms of outcomes? We know that of the women who received the vaccine, which is here, there was a total of 827 women who were analyzed. This is from a total of 3,958 women. They were looking mostly at women who were vaccinated. And most of the women were vaccinated in their second trimester. And they're reading out a cohort of 827 who'd completed their pregnancies, 700 of which had completed had received their vaccines in the third trimester. So we're looking at most of the women were from their third trimester. They're now giving birth to their children. And what do we see? Well, we see that of the 827, that 13.9% of them had fetal loss. So that was basically either stillbirth, but mostly miscarriage. And we know that you can't miscarry in your third trimester. So there was a total of 804 women of the 127 that weren't third trimester, which is a rate of 81% who miscarried. So of those women who had live births, which is this thing here, we know that most of them, basically 86.3%, had normal births, but that there were some preterm births, some smaller sizes, and some congenital anomalies there, up to 13.7%. When we were looking for comparators, we looked at the Health Canada database, pregnancy database, and we noted that 75.1% of all pregnancies in Canada are live births. That a subgroup is induced abortions, but only 2% are miscarriages. So in a group of women with clinically confirmed pregnancies, the rate there is 2%. If we look at other databases, like for instance, numbers in the UK, we see that the rates can be as high as 25%. In early pregnancy, up to 4 weeks, but later in pregnancy, it should be about 0.5%. Some reports have said 1%. So the authors of this particular report basically say that that the rates seen in this trial, the 13.9% rate here, is not outside of the published literature. However, we do know that rates for third trimester should be much lower. And it also highlighted that this really does not reflect outcomes in the first trimester vaccination, which is where we would suspect the most adverse effects. So moving right along to passive surveillance now. Passive surveillance means that you're basically vaccinating people and sending them home. And they're going about their daily activity and they notice that something is off, and so they stop, make the link between the vaccine, find the number, research the number to call and call in an adverse event. They might talk to their doctor who might call it in. So we know that 221 pregnant women reported vaccine suspected adverse outcomes. So they were vaccinated and they said, hey, something awful has happened, and they called it in. So we know that generally reporting in passive surveillance systems is underreported, just because it's usually quite an ordeal to try and report something, and usually people aren't even thinking about it. However, of the 221 adverse reports from pregnant women, 76% of them were fetal loss. And the most frequent of all of those was miscarriage. So for pregnant women, about a third of the vaccine suspected adverse effects reported were pregnancy related. And of those, 76% were fetal loss. So that's the US, the CDC VAERS system. So we double checked it with the UK yellow card system, which also is a passive surveillance system that records vaccine related adverse outcomes. And in this particular one, there in England, 90,000 people were vaccinated. So there's no data related to the time of vaccination. However, of the 77 pregnancy-related vaccine suspected AEs, 74% of them were fetal loss. So we do see a consistent signal that of the adverse events reported by women, that miscarriage is the most common. So again, if we look at statistics for miscarriage, we know that in the UK that 25% is common early in the pregnancy, the preclinical stage, but later in the pregnancy, the rate should be much lower. So other considerations. We know that there are social considerations. Potentially, there might be a thought that you'd want to get vaccinated in order to help develop herd immunity and reduce transmission of the virus. However, it is important to remember that vaccinations have not been shown to reduce transmission, that is speculative, and that vaccine breakthroughs are becoming more common in terms of being reported. So that means that even if you are vaccinated, there is a potential of you getting a COVID infection. So the other thing too is we can reduce risk of exposure. So if you never get COVID-19, then you and your baby will be safe from, will have the lowest chance of being exposed to the spike protein. And one of the things to consider is lowering your overall exposure, but also surrounding yourself with people who are immune either through antibody test or vaccination. Finally, there's other health considerations. You can try and lower your risk of severe risk factors by considering weight, making sure that your vitamin D levels are up, and reducing your intake of sugar, because all of these have contribute to the virus being more severe in somebody. So what have we covered so far? We've covered a lot of areas. So we've considered the risk of disease. Of course, your risk is lowest if you never get COVID. However, most pregnant women who do get COVID recover without severe disease and develop immunity, and that immunity is conferred to both them and their children. Pregnant women are at a low absolute risk of severe disease, but it's higher than non-pregnant women. And there is a small but increased risk of preterm birth and preeclampsia with severe disease. So those are considerations in terms of risk. When considering vaccination safety and efficacy, we need to remember that the case for safety and efficacy in pregnant women has not been made in a randomized controlled trial, so therefore we cannot prove that it's safe. We do know that in healthy adults that there are reports of greater than 90% efficacy in reducing PCR confirmed cases, but when that comes to COVID-like symptoms, it does not reduce COVID-like symptoms. And in fact, pregnant women who were vaccinated, all 12.6% had severe fatigue, 9.4% had severe muscle aches, many more had injection site pain, headache, and chills. So severe disease in this case means that you're not able to carry on your daily activities. In terms of reports of safety from active surveillance, there's reports of 13.9% fetal loss. And that's when most women were vaccinated in the third trimester, and the greatest risk is in the first trimester. And adverse neonate outcomes were seen in 13.7% of live births. So we know that through the passive surveillance system, that's whenever your unsolicited reports and people basically report suspected adverse effects from vaccines, that more than 70% of the adverse outcomes that were reported by pregnant women were miscarriages. So what are your options? Again, if you limit your exposure and never come in contact with COVID, that's the best scenario. If you do come in COVID, we know that most women will do well, but there's also an option to reduce your risk factors, if at all possible, by bolstering your natural immunity. And of course, some women who won't be able to reduce exposure or who might have other high risk factors may in fact think that vaccination is a good option. So in terms of informed consent, we need to be considering risk of severe disease, the safety and efficacy of vaccines, as well as your personal situation. So I really encourage you to take this video and the information that we've discussed and bring it to your healthcare practitioner and have a robust, fact-based conversation. And that helps you make an informed choice.
Thanks for watching. Please comment, like, share, and subscribe.